having an anesthetist who's awake rather than he's walking in like this, would you like an epidural, right? I think you want the one that's awake, right? And you don't want to call him back at 3 o'clock in the morning. Yes?
How long does the epidural last?
It lasts for the length of time that it's in. We're going to go through the whole process. I'm going to explain to you what's involved. So if you've decided that you want an epidural, okay, here's the process. You will have an intravenous in. They're going to run in some fluids, hopefully at least about 1 liter, sometimes more, of intravenous fluid, because they want you hydrated before the procedure. They're going to sit you up. Sometimes they'll do it with you lying down and have you curled up and push your back out as much as you can, and that just opens up the spaces, okay, so that he can put the epidural in. Now, sometimes they put the epidural in at the L2 space, sometimes L3, okay? You have 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then the sacrum, okay? And that needle has to go into a proper space called the epidural space. Epi, outside, dura, the dura that covers the cord, epidural, okay? Outside. If it goes through the covering of the cord, it's a spinal now. It's transdural. We don't want it to be transdural. There are specific times when we want a spinal, and I'll talk to you about that in a second, and there's specific times when we want an epidural. And now we're talking about an epidural. So he's going to use a special needle. I'm going to show it to you next week. Don't get too focused on it. It's a big needle. You can go hunting with it. Don't focus on that. Does it hurt? Yes?
If you have a tattoo on your lower back, can you get one?
Almost always they can find a spot where the tattoo is. Now, are they going to go right through the ink? They are not. So depending on exactly where the tattoo is, that will determine whether you're going to get an epidural. And each of them, each of the anesthetists is a little bit different. So if the tattoo is fairly low down, right down here, you're fine. If it's up here, maybe it's an issue. So again, each anesthetist is going to be different. He's going to look at you and say, you've been inked, goodbye. Somebody else will say, it's not important. I can find a spot, and he'll put it in. So each of the anesthetists is a little bit different, and just having a tattoo doesn't mean you can't have an epidural. Okay? All right? So the anesthetist is going to prepare the skin. He's going to prep it, sterilize it. And they're going to put in some local anesthetic to freeze the spot. And then you're going to have to bend to open up the space, and he's going to try and feel exactly where it goes, because this is done by touch. It's all done by feel. And the epidural space is a relatively small space, about 1 centimeter. And that needle has to go into that spot. And it's done by feel. As he goes through the ligaments, he can feel exactly where he is. If he gets fluid back, he went too far. We'll talk about that in a second. So it's got to go into the epidural space. That space is about 1 centimeter. In some girls, it's more than 1 centimeter, it's bigger. And in others, it's smaller. Our anatomy varies a little bit, right? We're all basically like that, but yeah, some of us are like this and some of us are like that. So that accounts for potential problems as well. So he feels where it is, puts the needle in, and then what they do is they put a small catheter through, and I'm going to show it to you next week. It sits in that space, they tape it on, and then hook it up to a pump, and it delivers a small amount of anesthetic continuously. It's called a continuous epidural. Now, it's possible for you to get what's called a one-shot epidural. Just one push. And that's what they used to do 25, 30 years ago, and in some places still. You would be in labor, you're fully dilated, you're pushing, we can see this much of the baby, and they'd flip you over and stick a needle in your back and freeze you. So you were in labor for 16 hours with minimal pain relief, and now we're going to freeze you for the last 15 minutes. Not a good idea. Why not do it back here, right? And let you at least have 8, 10, 12 hours of good pain relief, right? And the difference is going to be like night and day. You're in pain, you're having contractions, you're screaming, you're uncomfortable, and once the epidural is starting to work, you are smiling. And you say, different world, different world. With the one-shot epidural, it's a large amount of anesthetic that's given. With the continuous epidural, it's a very small amount that they give initially, and then they hook it up to a pump, and it delivers a very tiny amount of anesthetic continuously. So how long can you have the epidural? You can have it for as long as you need it. You're in labor for another 10, 12 hours, you have 10, 12 hours of pain relief. Could you have a cesarean section under epidural? Of course. Absolutely. Will you be able to push? Because there are a number of issues with this epidural. Some people say, don't have an epidural. You're going to have back pain for the rest of your life. True or not true? I don't believe it. Now, having said that, sometimes it's really easy to put in the epidural. He gets it in first try. Sometimes they've got to try a couple of times. Could that cause a little bit of discomfort afterwards? It could. I'm not going to lie to you and say that there's no possibility. Absolutely there is. But is an epidural usually the cause of back pain for the rest of your life? Virtually never. Virtually never. Okay? The back pain that girls have afterwards is from weight, from the bending that they've had to do, and from carrying the baby. It's all kinds of things. It's not usually from the epidural. So, is it a possibility? Yes. Is it likely? No. Some people say, don't have the epidural. It'll stop your labor. It almost never slows it down. In fact, by making you relax, it may even speed things up a little bit. Okay? Do we need to induce people to give them oxytocin more often once they've had an epidural? That's hard to answer. Sometimes we do and sometimes we don't. But in truth, we can use oxytocin afterwards to make the labor a little bit faster and move it along, because now you've got pain relief and you're not feeling anything. So is there a bigger incidence of oxytocin use once you've had an epidural? Absolutely. I'm 100% convinced of that. All right? Does it make a big difference? Sure. It makes a big difference in how you look back on it. Okay? You're going to look back on the day and say, I managed. I tried it out. I felt the contractions. That's enough. Thank you very much. Now, technical things. When that anesthetist is putting that needle in, hold still. When he says hold still, he means it. He's got a needle. He's pushing it into your back. He needs to get into a small space. Try really, really hard not to move. If you feel that there's a contraction coming on and you're going to move, tell him, I'm having a contraction, stop for a minute. He'll stop. He doesn't want to end up with a complication. He'll stop. He'll wait for the 45 seconds. Once the contraction is over and you can relax a little bit, he'll proceed and he'll put the needle in. Now, it has to go into a very small space. Okay? If he goes too far and goes through the covering of the cord, now it's not an epidural anymore. Now it's a spinal. And it's a different issue. Okay? Is it a risk? Yes. Does it happen very often? No. Are there complications? Sometimes. And I want you to understand what they are. Okay? So that you know what your risks are before you get into this. Is that fair? Okay. If you get an epidural, it's going to freeze you from the waist down. Okay? You're not going to be able to walk around anymore. You'll be able to feel, but you're not going to be able to feel pain. And you're not going to be able to walk. We don't do walking epidurals here. Okay? Although it's an experimental thing and it's being done in other places where it blocks the sensory nerves but doesn't block the motor nerves. So you can still walk. Here, once you've had an epidural, now you're parked in bed. Okay? If I put a needle through your skin, you wouldn't be able to feel it, but you could still move your leg a little bit. All right? We're going to turn you from side to side. Now we're not going to let you labor on your back continuously. And we may very well put a monitor on so that we're monitoring the baby's heart rate and we're monitoring your contractions on a continuous basis. I'll get to you in 1 sec. Okay? Fair? If the needle goes into the wrong spot and goes through the covering of the covering of the cord is relatively thin. It's a little bit like a hard-boiled egg. Okay? You take an egg, you boil it, and now I say, peel the egg, but that membrane that's just under the shell, don't tear the membrane. The membrane that's right under the shell is really quite thin. And if I said to you, peel that egg without tearing the membrane, take as long as you like. Use a microscope. I'll give you tools. What is the likelihood that you're going to be able to peel the whole egg without tearing the membrane? I say to you, it's probably 0. At some point, you're going to tear it. So the consistency of the dura is a little bit like that membrane. It has some strength, because we've all peeled an egg and taken off a big piece of shell and the membrane's still there. It didn't tear. And then another spot, it tears very quickly. Right? So the consistency of the dura is a little bit like that membrane. Some strength, not a lot, and easy to go through. If he goes through, it makes a hole. And I'm going to show you the needle next week, and it's a relatively big needle. So it's a relatively big hole. And if you get a hole, you might get a leak. Okay? And if you get a leak, you might get a headache. And it's called a spinal headache. How often does that happen? Not very often. First of all, let me tell you, how often do they actually get a spinal when they want an epidural? And the answer is maybe about 1 in every 100. Okay? About 1 in 100. Could be a little bit more, could be a little less. In this hospital, they probably put in about 1,400, 1,500 epidurals a year. Okay, we do about 2,500 deliveries, and they probably put in about 1,500 epidurals. So we're going to see 10, 15 of them a year. The vast majority have no problems at all. They have a spinal, they don't get a headache. Once in a while, you do get a headache. And I don't want to downplay the headache. A spinal headache is a colossal headache. Okay? It's a colossal headache. It's like having a migraine that goes on for 4 days. And there's nothing you can do to take it away. It's hard to look after yourself, the baby. We've got you lying down as much as possible. It's a bad headache. And if you get a spinal headache and you get a leak, they may need to do what's called a blood patch. So what they'll do is they take some blood out of your arm and they inject it into the epidural site to try and block the hole. And usually that works. Once in a while, it doesn't. The hole always closes over. You're not going to have a headache for the rest of your life. But could you have a headache for a couple of days? Yes. Is it the anesthetist's fault? I don't think so. It could be that the space was this big instead of that big, and as he's putting it in, he's through. It happens. And once in a while somebody moves, and once in a while he just puts the needle in too far, and you get a spinal. If you get a spinal and he doesn't inject the anesthetic, it's okay. It's not the end of the world, because he's going to inject some local anesthetic. Now, when it's an epidural, it goes into the epidural space and it freezes the nerves as they're coming out of the spinal canal. It's a local anesthetic. It freezes the nerves so you're frozen from here down. If it goes through, it mixes with the fluid that's around your cord, and it can rise. Okay? This fluid that's around your cord is also around your brain, cerebrospinal fluid. It rises. And what happens when a girl gets a spinal by accident is that she says, I'm feeling some numbness and tingling in my fingers. Now, we want you frozen from here down. If you're getting freezing, numbness and tingling in your fingers, where are you frozen to? You're frozen to here. Because the nerves that come off to your hand come off from the brachial plexus, right? C4, 5, 6, and T1, or 5, 6, 7, and T1. Low down, okay? But you're frozen to here. And just above that, this far away, in the brainstem, is your breathing center. And if it rises all the way up to the point where you're having breathing problems, we have an issue. Does that happen very often? No. Is it a possibility? It's a very uncommon possibility. But for those girls who are having breathing problems because they got a spinal by accident, or they stop, because if you freeze your breathing center, what happens? You stop breathing. You're awake, but you're going to know exactly what time you died. If you stop breathing, if you got a spinal and you stop breathing, what would happen? Well, that's an emergency. The anesthetist has got to come and put a tube down and ventilate you, attach you to a ventilator so that the machine is breathing for you. You're not going to die. We're not going to let you die. But it's one of the reasons why the anesthetist has to be there, right? There are always risks. The risks are small, but the risks are not zero. So the anesthetist has to know that this is not happening. The nurses need to know it's not happening. Because if it did, they'd have to put a tube down and put you on a ventilator. The machine would breathe for you. You wouldn't be very happy. You're awake. You're in labor.
It's like having an asthma attack in labor.
Yeah, that would be awful.
No thanks.
Exactly. So there you are. You're now on a ventilator. And the anesthetic would wear off, and you probably would reach up and pull out the tube. And once you can reach up and pull out the tube, you're breathing on your own. Right? You just would have a bad memory. Okay? So once in a while, there is a rare complication. Having a spinal it's a complication. It's not that rare. Having to go on a ventilator, extremely uncommon. But I need you to know that it's a potential risk. Okay? So you need to know this. Is the risk that big that I wouldn't have an epidural? Absolutely. I wouldn't. I'd have the epidural. The risk is extremely small. All right? Once the epidural is in, you're frozen, you're comfortable. Now, the level of comfort can be different. Sometimes the epidural works great. And sometimes it doesn't work so well. Once in a while, it needs to be redone. It's variable. But most of the time, you get excellent anesthesia from it. Just excellent anesthesia. Some people say, don't have an epidural, you won't be able to push. True or not true? Well, again, these stories don't come from outer space. Most people who have an epidural are still able to push, and they're still able to push effectively. Sometimes you can't push. Sometimes you can't push. What do? Well, it's a machine that's driving it, right? It's a pump. We just go to the pump and push the off button. Turn it off. And within about 20 minutes, you'll push, right? You'll start to feel your contractions. You'll feel that uncontrollable urge to push, and you will push, okay? So we can manage it. If you're okay with the epidural and you're pushing effectively, great. You've got good pain relief. It's okay. But if, for whatever reason, you can't push well, I want you to push. We'll just turn the epidural off. All right? Is that fair? We'll turn it down or we'll turn it off. And we can always turn it back on again, right? Because I want you to push. This is about you having the baby. It's not about me having the baby. Because when the time comes for you to push, it's work. It's really hard work. For most people, it's hard work. So here you are, you've been in labor, cervix is dilated, you're opened up completely. I've examined you, or the nurse has examined you, we check the position of the baby, and now we say, it's time to push. It's time for you to work. Okay? We're going to work with you. I'm going to help you as best I can. I'm going to get on one side, your husband's going to get on the other side, or the nurse, and we're going to get you to push, because this is about you having the baby. Everybody will push for a different length of time. For some people, it'll be 20 minutes. For others, it's going to be an hour and a half to 2 hours. Pushing for 3 hours, I think that's getting a little long. I think by 3 hours, you're exhausted. And if you haven't pushed the baby out by 3 hours, what makes you think you're going to push it out in the next half an hour after that? As long as you're making progress, I'm going to let you push. Again, this is about you having the baby, not about me having the baby. There are 3 ways to get a baby out. Number 1, you push it out. Number 2, I pull it out. Number 3, I cut it out. I want you to push it out. I want to sit in the chair and do as little as possible. Okay? My old professor said that an obstetrician should have a big cigar and a fat ass. Get out of the way, let her do her work, sit in your chair, wait. Let Mother Nature do this. Let her push this baby down. And you know what? It's good advice. Because a lot of times we interfere a little bit too early, we meddle a little bit too early. But, there's reasonable and not reasonable. So I want you to do this. And if you can push effectively, that's great. I'm going to stay out of the way as long as possible, and I'm going to interfere when I need to. And hopefully, you're going to push this baby down, and I'm not going to have to do much except catch it, right? Next week, we're going to talk about what happens when I need to interfere, right? What happens when it doesn't go the way it's supposed to go. But a lot of times, most of the time, you're going to be able to do this. How long will you need to push? Everybody is different. It's going to depend on the size of the baby. It's going to depend on your effort. It's going to depend on position of baby. Is it easier to push out a 7-pound baby than a 10-pounder? Sure. Is it easier to push out a baby that's in good position than bad position? Absolutely. And is it easier if you've got a big pelvis than a small pelvis? All of these things. Okay? All of these things. How much do I need to do? It's going to be different for every one of you. Okay? Each and every one of you is going to have a unique situation with respect to an episiotomy, with respect to assisted delivery, with respect to cesarean sections. And we're going to talk about all of those issues next week, because cesarean sections are in everybody's mind. And in fact, the cesarean section rate in this hospital is over 30% now. That's really high. That's really high. So it becomes an issue as well. Okay? Now, somebody had asked me about the cord blood program, right? And I want to talk to you a little bit about it right now. And some of you may have heard about it, okay? Cord blood program. And what this involves is saving the blood that's in the cord and the placenta. And before I talk about it, I'm just going to show you a placenta because I brought one. Okay? So no crying. This is not one of my patients' placentas. It's somebody who delivered last night. And I asked them to save the placenta for me so that I could bring it to the class today. So this placenta is a couple of hours old. And here it looks like a steak. So let me just turn it around for a second so that you can see what we've got. Here's the cord. And this cord is now empty. And you can see about how long it is. And I don't know how much of it they've cut off, but there's a good length to the cord. And it inserts approximately into the center of the placenta. All right? Right about there. Now here are the membranes. Okay, so this is the sac that the baby was in. Okay, you can see that there was a sac that the baby was in, and you can see that the membranes have some strength. But at the same time, once they tear pretty easily. This is the part that was against the mother, and this is not a particularly big placenta. This is, in fact, a relatively small placenta. But you can see that it's, about a pound, pound and a half, right? So the placenta is about a pound and a half to 2 pounds. Most placentas are a little bit bigger than that. And there are issues with respect to where the cord is implanted. This cord is implanted a little bit off to one side. Sometimes it's right in the middle. Sometimes it's not in the middle, it's off to one side. But as long as it's well into the body of the placenta, it's usually not an issue. It becomes an issue when it's implanted right on the edge. Right on the edge, it's a marginal insertion. Sometimes that can be a problem, and we don't know. And once in a while, rarely, it can be implanted onto the membranes. It's called a velamentous insertion of the cord, and that can be a real issue because the membranes are quite thin, and if they tear, baby can bleed. So it becomes an issue then. All right? So the placenta and the cord and the baby are all baby. And the blood that's in the placenta and the cord on this side of it is baby's blood. And what we do is we collect as much of the blood as we can from the cord. And we send it out and it's preserved. So cord blood program, what's it about? It's about stem cells. And everybody's heard about stem cell research. And this is relatively new and young. And we don't know where it's going yet. The idea is stem cells are progenitor cells. We can turn stem cells into anything. So right now, it's not that useful. But there's an enormous amount of research being done. And will it be useful in the future? Sure. At what stage in the future will it be useful? I can't tell you. Is a major breakthrough going to come? Yes. Will it be 10 years or 20 years or 30 years from now? I don't know. Will we eventually be able to grow a kidney from cord blood cells, from progenitor cells? I don't know. Maybe. A heart, skin, who knows? Right now, it's not useful for much. But here's the whole story. So I want you to understand before you make any decisions about whether to get involved or not. It started out as a research project at Mount Sinai Hospital. And it was a not-for-profit program. Okay? Whatever money it cost to get into the program, and when it started out, it was around $1,500 to $2,000. I mean, it costs so much to prepare the cells and all of that. And then the rest of it, the profit, if there was any profit, went into research. So it was essentially a non-profit program. But that program was sold. And now it becomes for profit. And there are several companies in Toronto and across Canada who are now doing cord blood preservation. Okay? It is a for-profit program. You have to understand that, because there's a lot of money involved in running it and in advertising it and promoting it. And that money has to come from somewhere, and it's coming from you. Is there any value to it? What can you do with it? How do they preserve it? Here's what's done. At the time of delivery, we collect as much of the cord blood as possible, and then it's sent out to whatever company you've selected. They select out the stem cells and then freeze them. and it's a small amount. Okay? These stem cells are then frozen, they're prepared, and they're frozen in liquid nitrogen. Frozen is frozen. It's not like you put it in the fridge. It's not in the fridge. It's in liquid nitrogen. Liquid nitrogen is really, really, really cold. Okay? And it can stay frozen forever. How long can you keep these cells? You can keep them forever. Who do they belong to? They belong to the baby. They belong to that child. You have control over them, I guess, until the child is of legal consent, legal age, and then those cells belong to that child. Okay? Can they be used by anybody else? Can they be used by another child? Probably not. Can they be used by you? Probably not. Maybe, 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 but probably not, because that child is unique. It's 50% you, it's 50% her. It's 100% the child. So there you are. You've saved some stem cells. Stem cells are cells which, under proper circumstances, can be stimulated to develop into other cells. What is it useful for now? And has it been used very much at all? And the answer is, it's useful for rare diseases that they're experimenting with, and the most common, I think, is childhood leukemia. So leukemia is cancer of the blood. What happens when someone gets leukemia? Well, if you don't treat them, they're probably going to die. If a child gets it, it's a big issue, right? What happens? We treat the child with chemotherapy, and then hopefully there'll be a response, and the child will go into remission. And sometimes it's a long remission, and sometimes it's not, and they get a relapse. And now they go to the family and say, we need to do a bone marrow transplant. Okay? We need to do a bone marrow transplant. And we see if anybody in the family is a match. So they take blood from you and siblings if they're available, and aunts and uncles and cousins and second cousins, and from the extended family, seeing if anybody is a match for that child. Because the treatment now is chemotherapy, and then it's bone marrow transplant. Okay? And what they do before they do a bone marrow transplant is they radiate them. They kill the bone marrow. If you kill the bone marrow, you can't make red cells, white cells, and you're going to die unless we give you a bone marrow transplant. Right? So this is relatively new, and we want to have the best possible match. Right? The best possible match. Well, the best possible match for that child is that child. And if you've frozen some of those cells, you've given that child a second chance at life. And unless that child has an identical twin and go to his brother and say, I've got a problem. I have leukemia. Can I have some bone marrow from you? And you've got a perfect match. You're identical twins. Great. On the other hand, that twin might say, bye. No. But if you've got and none of us in this room have an identical twin. So there's the problem. If you don't have an identical twin, here's this one opportunity at the time of birth to save some stem cells. Now, are they likely ever going to be used? Childhood leukemia is an uncommon disease. Are they likely ever to be used? The answer is probably not. Probably not. You're probably not. You don't ever want to use these cells, right? They're frozen. You don't ever want to use them. It's a little bit like life insurance, right? When you buy life insurance, you're looking down the road to protect someone, usually your family. And when the life insurance pays off, guess what? You lost, right? You died. You're young. You don't need life insurance. You just got married. You don't need life insurance, because if you die, she's just going to get married again with your money, right? But now all of a sudden you have a child. You want to protect your child, right? Not protecting her. You know what I'm saying, right? You want to protect your family. So it's insurance. Is it worth it? And the answer is, I don't know. I don't know. The price has come down because it's competition. It's now about $1,200, $1,300. You don't have to lay it all out at the same time. And then it's $100 a year. I think that pays for 10 years. I think. And then after that, it's $100 a year. The $100 a year is not an issue. We all have $100 a year. It's, do you have the $1,200, $1,300 to spend to get into this, knowing and hoping that you'll never use it? And the answer is, I don't know if you should do it or not. I don't know. The research at this time is primitive, it's early, and I can't give you good advice as to whether you should do it or whether you shouldn't. Let me just give you an example. 2 of my girls just had babies, and neither of them got into the program. And it's not because they couldn't afford it. I would have paid for it if they wanted it, but they made the decision not to. And they knew about the program. It's not like they didn't know. So neither of them chose. But having said that, lots of people are choosing to do it. So I can't tell you what you should do. The program is available. Hopefully you'll make a good decision for yourself. And my advice is, there are a number of pamphlets in the office, and there's a DVD available from one of the companies that if you want, I'll give it to you so that you can play it, understand a little bit more about the program, and make a good decision for yourself as to whether you want to get involved. There's a 1-800 number for each of these companies. You can call them up, get some information. They'll, I'm sure, send you out whatever you need, and then you'll make a decision for yourself and for your family as to whether you want to get involved in this. But you need to make this decision before. You can't make the decision, now I'm in labor, save my cord blood. That's not how it works, because there's a package and there's all kinds of preparation that needs to go with it, so you need to prepare in advance. So if you're going to do it, this is something for you to think about now and not to think about at the last moment, okay? But can I tell you whether it's going to be useful or not? I can't. I suspect that at some stage in the future it will be useful, okay? Whether you're ever going to use it or not, I can't say. And what will it be useful for? I can't say that either. But I mean, this is primitive research, and it will go somewhere, without a doubt. We were looking after 28-weekers and had terrible results with those babies, and now we have excellent results. So we've made enormous progress. Will we make enormous progress with this as well? For sure we will. Okay? Any questions about it? Now, when we talk next week, we're going to talk about what happens when it all goes wrong. What happens if everything I said to you is a lie? The epidural doesn't work. You can't get an epidural. You can't push the baby out. You have bleeding. There are complications. You need a cesarean section. The baby's in bad position. I don't like the tracing of the heart. All kinds of potential problems. So what if it doesn't go the way it's supposed to go? And we're going to talk about all of those issues next week. Okay? Is that fair? All right. Now, questions?
With epidural, how can you lay on your back if you have the needle?
The needle is not in your back. They use the needle to get into the proper space, and then they put a small tube in, and then that tube is taped to your back. I'll show it to you next week, so you'll see exactly what we do. And then you can lie on your back. But when you have an epidural, let me tell you, we don't let you lie on your back for a long time, because it can make your blood pressure fall a little bit. That's one of the reasons why we want to run in at least 1 liter or 2 liters of fluid before. Because sometimes when you get an epidural, the baby's heart rate goes down a little bit. And is it a concern? It is a concern. It almost always recovers fairly quickly, but there are some small issues. So we turn you from side to side once you've had an epidural in. We don't let you stay on your back for a long time. And almost always we're going to put a monitor on to monitor the baby's heart rate and monitor your contractions. Okay? Because you're not going to be feeling your contractions. If I come into the room and I say, Julia, how often are you having contractions? You're not going to be able to tell me. I'm going to have to look at the machine. Or I'm going to have to sit down beside you, put my hand on the uterus, and feel the contractions. And I do that from time to time. Okay?
So it doesn't affect the baby except the heart rate?
That's the only thing that it does to the baby. Okay? Is it going to cause any big problems for your baby? Almost never. Almost never. Now, one of the questions that everyone asks is, when do I come to the hospital? When do I come to the hospital? Do I live in the hospital? Everybody thinks I live in the hospital, but I don't. When do I come to the hospital? I come to the hospital when they need me. Remember, I do my own deliveries. There are 2 departments. There's them, there's me. In most hospitals, virtually every hospital, there's 1 person on call each day. And the obstetricians will take turns being on call. So if your doctor's on call on Monday, he may not be available, or she, again for Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, and maybe into the next week. I don't know. Depends on the size of the group. In some hospitals, they may have a group of 14. So you might be on call twice a month. That means for the other 28 days, you're going to get somebody else. And the call systems vary in different hospitals. In some hospitals, you're on call for 24 hours. In other hospitals, it's for 12 hours. You're on, you're off. And in other hospitals, everybody does their own deliveries during the day, but one person's on at night. So it works that way in this hospital too, except that I do my own all the time, and I'm not part of the call schedule. So I'm around a lot, sometimes every day, sometimes 2-3 nights in a row, then I really get tired. So when do I come to the hospital? I come to the hospital when they need me. The nurses call and say your patient is ready for delivery or she's moving quickly, and they call me. And it's usually not an issue. I'm there for the delivery. I'm not there for the whole length of the labor. I'm not. But once in a while they'll call and you're 3 centimeters dilated and there's a problem with the fetal heart and there are issues. So I'll give you an example. On Friday night, I was called in. A patient of mine came in having her 5th baby. Okay? 4 babies already, all normal deliveries.